Thank you for listening to this module. My name is Nancy Santesso from the Grade Center at McMaster University, and I will present this module over the next 10 minutes about the process of making a recommendation during a guideline panel meeting. In particular, we'll illustrate how to use the evidence to decision table in the grade process. In the past, we found that guideline panel meetings could be quite chaotic and disordered, and it was often unclear how a recommendation was made and on what it was based. At times, the guideline panel discussed some issues, but other issues could be missed. For this reason, the grade approach uses a table to guide the process. The table includes all the factors that are important to consider when making a decision. The table is set up to ensure that all factors are discussed and the decisions are recorded. Before a guideline panel meeting, the methods group gathers and synthesizes evidence to assist the guideline panel to make a recommendation. The table includes evidence about a variety of factors, including the priority of the problem, the benefits and harms, the certainty of the evidence, the values and preferences of patients, resources, issues around equity, acceptability, and feasibility. All of the factors are discussed in the same way. The table is laid out into 4 columns for each criteria that we listed in the previous slide. To ensure that the evidence is discussed, any additional points from the panel are considered, a judgment is made, and recorded. In this example, the panel must make a judgment about whether the costs favor recommending the option. Let's take an example to show how the table is used. Here we use a question about recommending hip protectors for the frail elderly in long-term care facilities. Hip protectors are specially padded undergarments which may protect the hip when someone falls. And the guideline panel wanted to know whether to recommend frail elderly in long-term care facilities who are at high risk of fractures should wear hip protectors. So the methods group searched for evidence and information for all of the factors and filled in the table. Here is the evidence decision table, and I will take you through how the table was used by the panel to make their final decision. First, the panel agreed that hip fractures is probably a high priority issue in the frail elderly, as hip fractures occur in up to 6% of people. And in particular, they've discussed a major concern of hip fractures as the serious long-term consequences. Next, the panel considered the benefits and harms of hip protectors. In this case, we conducted a systematic review of the effects of hip protectors on hip fractures, falls, mortality, and so on. The evidence for each outcome was assessed, and it was moderate, low for most of the outcomes. And the panel decided that the overall certainty of the evidence was low. The panel is then asked, what is the value that people place on these outcomes? How sure are we about this? Or is there variability about the value that people place on these outcomes? In this case, the evidence we had indicated that we were probably certain that most people would place a high value on avoiding hip fractures and the related pain and the higher risk of mortality, and that people with high risk of fractures value these outcomes more than the inconvenience of wearing a hip protector. Next, the panel considered whether the benefits outweighed the harms. But first they answered how substantial are the desirable effects, and in this case they looked at the reduction in hip fractures, which was 10 fewer when wearing hip protectors, and mortality, which was 5 fewer deaths when wearing hip protectors. And they decided that the desirable effects were moderately substantial. Then they considered how substantial the undesirable effects are. And they looked at the increase in pelvic fractures, which was 2 more, and the reduction in quality of life. And they decided that the undesirable effects are small. Then the panel needs to decide whether the balance between desirable effects and undesirable effects favor the hip protectors. The panel agreed that the benefits were moderate, the harms were small, but overall they had low certainty in the evidence. But the desirable effects probably outweighed the harms, and therefore the balance of effects probably favored hip protectors. Next, they considered what we knew about the resources. So we looked at evidence about resources and costs about the hip protectors and graded that evidence. We used some evidence from the local setting, for example, how much it costs to purchase the hip protectors in Canada, and also evidence from economic analyses about the cost of hip fractures and other important fractures in Canada. However, a full economic analysis was not conducted, and we were not certain about the effects we found. So there was low certainty in the numbers we calculated. When the panel compared the cost savings of preventing hip fractures compared to the cost of hip protectors, which ranged from $68,000 per 1,000 residents to $188,000, they thought that the cost probably outweighed the option of providing hip protectors. It was also important to consider other factors. For example, the cost of hip protectors are not covered by long-term care facilities or by most healthcare plans in Canada. Therefore, people who cannot afford hip protectors may be at a disadvantage. It was therefore important to consider how the recommendation might impact health inequities, and this panel found that the inequities probably will increase. Another important factor is whether the option is acceptable to most stakeholders involved. There is a lot of discussion about adherence to wearing hip protectors, and most studies found a range of adherence from 24 to 80%. The panel also agreed that staff in long-term care facilities will likely have to help residents to put on and take off the protectors, but this would be part of the usual routine of dressing. And so the panel agreed that the option would probably be acceptable to most stakeholders. In addition, there was some concern about whether hip protectors would be feasible to implement if recommended. Although there was no evidence, the panel discussed the issue and decided that it was probably feasible to nursing and the care staff and the laundry staff to provide access to hip protectors. Now that all issues were discussed and judgments recorded, the panel could look back at the table to summarize the discussion clearly. They summarized it as treating hip fractures is probably a priority. The benefits probably outweigh the harms, although there is low certainty in that evidence. There is no variability in values placed on benefits and harms, although again the certainty of the evidence was low. That it was probably cost effective, but again low certainty in evidence. It was probably acceptable to key stakeholders. It was probably feasible to implement, but inequity would probably increase. Now the panel was ready to make the recommendation. When making recommendations, the panel needs to decide on the balance of the undesirable and desirable consequences. And it's not just about the benefits and harms, it's all of the factors. By looking back to all of the decisions, the panel could see that when considering the factors, that they probably favored the option of hip protectors. And overall, that the desirable consequences probably outweigh the undesirable consequences, and that they would suggest offering hip protectors to frail elderly who are at high risk of fractures. The rest of the table is dedicated to summarizing the judgments so that readers can understand how the decision was made. Here is where the panel writes the text that will accompany the recommendation, and it is a summary of all of the factors that were considered during the discussions. The full completed table can be kept as a transparent record of all the discussions and can be provided for people who are interested in the details though. The evidence to decision table is a tool with multiple purposes. It lays out what evidence is needed for the decision so that the team can pull together all of the evidence before making a decision. But then it is also a valuable tool during the guideline panel meeting to facilitate and guide the discussions to make the recommendations. And it is a tool for users who are interested in how the decisions were made and what was considered. For more information about how to move from evidence to recommendations, please see the article listed here. We also have a couple of websites available. There's one from the Decide Grade project, which will provide a link to this tool, the Evidence to Decision table, and also publications available at the Grade Working Group website.